to North East Yorkshire Psychological Professions Week session. I apologies for the ping as you hear people join. If everybody could please keep on mute, because this is a normal kind of Teams meeting. I think I forgot to ask the presenters. I think there's an opportunity at the end of each talk to maybe ask a question. And then maybe if we have time, hopefully there'll be a panel session at the end. I'd ask people to remember this is an open session, so we have psychological professionals here, but we may also have members of the other members of the public and other stakeholders. So if you could just be mindful of that, that would be great. And so I'll start without any further ado. I welcome Dr. Kellie Jacques, and who's going to chair this session. Thank you.
Hi everyone, and welcome to this series of 3 talks focusing on inclusive early intervention, where we're thinking about improving access and voice in children and young people's psychological care. So I'm Dr. Kellie Jacques, I'm a clinical psychologist and I'm an academic at Northumbria University, and I'll be speaking alongside Cara Miller, who's an assistant psychologist with Northumbria University and also TZESC and Weir Valley NHS Foundation Trust. And we're going to be sharing some findings from our research looking at adapted low intensity practice in children and young people's mental health services before handing over to Nathalie Dullage from Northumbria University and the North East and Yorkshire Learning Collaborative to speak around a co-produced whole score approach. And then finally, we have a talk from Clare Devanney-Glynn with Northumbria University and the FASD Network UK, who'll be speaking about the role of parent and carer peer support workers in children and young people's mental health services. And as Sharon said, we're going to make some space at the end of each talk to ask any questions, and also there'll hopefully be a bit of time at the end overall to for any final questions. So I think that is everything. I'm just going to share the first set of slides for myself and Cara's first presentation. Okay, is that visible for everyone? Great.
Yes.
So me and Cara are going to be talking about adapted low intensity CBT for autistic children and young people and children and young people with learning disabilities. So a bit of a background and rationale to this research. So Children and Young People's Psychological Trainings Initiative was launched in 2011. It's formerly known as CYP, and the remit of this was to improve the quality and accessibility of psychological therapies for children and young people. And the low intensity arm of this focused on early intervention and workforce development. So a really key part of training these low intensity practitioners was helping children with mild to moderate mental health difficulties access support early in that pathway, rather than intervening at a later date when things might have got more difficult. By 2019, over 10,500 practitioners have been trained. So at this point, I don't actually have the latest figures. I was thinking about that this morning. I'd really like to know what the updated figures are. It's going to be a lot higher than that. So we've done an amazing job of training a huge amount of practitioners in this area. However, children and young people with autism and learning disability, or intellectual disability, depending on the terminology you prefer to use, experience higher rates of mental health difficulties, but they face reduced access to suitable psychological interventions. So although we've got this huge workforce that are working with children and young people, adapted practice, so knowing how to work with children who have learning disabilities or autistic kids, is not something that's part of the EMHPs, that's education mental health practitioners, people that work into schools, and CWP, that's child wellbeing practitioners, they work into the community. They don't have that training as part of their core curriculum. And so although they're out there working with these kids, and these kids are in our services and they are having intervention, what they haven't got is access to adapted practice in a really consistent way. There isn't an agreed framework for how we do this kind of practice. So like I said, we know that our practitioners are working with these children and young people, but depending on where they are in the country, where they've been trained, it really varies what training they might have had access to. So there are lots of different ideas about what we can offer, and there's no one standardized thing that we're doing. And with all of this in mind, it means that practitioners can often lack confidence working with these kids. They don't always have the guidance that they need or the supervision that they want when working with these populations. And I guess all of that to say that can then impact on that accessibility, because it might mean that children and young people who have a learning disability or are autistic might not have access to therapy that is the best fit for them. So we've been working at Northumbria on an overall research remit around looking at low intensity CBT practitioners and how they can better meet the needs of autistic children and young people and children and young people with learning disabilities. And we've begun this series of research by focusing on the confidence levels of the practitioners in our region, as well as the current practice adaptations that the practitioners in our region are already making. So we wanted to know, how confident are they feeling at the moment, given that they're doing this work, and what are they doing? What's their practice at the moment? So me and Cara are going to talk you through two projects. The first one I'm going to talk to you about is looking specifically at that confidence aspect of this. So how confident practitioners are working adaptively with autistic children and young people and children and young people with learning disabilities. So our aims were to determine the levels of confidence, but also to identify factors that are associated with increased and decreased confidence. And this is important for us because we wanted to be able to highlight which things we could do more of. So if there's something that helps someone feel more confident, can we do more of that to increase the confidence of this workforce? We used a quantitative design and it's cross-sectional. So we just asked people at one point in time, how confident are you feeling about this practice? And we use an internet-based questionnaire. The key things that we were, the key variables, the key things we were testing, we used two different therapy confidence scales, one that's specifically developed for people with intellectual disability, and one for people who are autistic. And we adapted those slightly so the wording was referring to children and young people specifically. We also asked for information about people's years of experience working, the frequency of clinical skills supervision, their job role and the duration in that role, whether they were qualified or not, or if they were still in their training year, what percentage of their caseload was made up with autistic children or children with LD, and if they'd had any additional training or continued professional development on these subjects in particular. We are really lucky to have a really great network around us at the university. So we used some convenience sampling. We reached out to these networks to recruit people through those channels. This included sort of alumni networks, community of practice forum, program leads, supervisors, and current trainees. And it was quite straightforward. We emailed out the information and a link to the questionnaire, and we had the questionnaire open for about 3 months. And in those 3 months, we had 121 responses for people within our region. So this was specifically for people working in northeastern Yorkshire. And as you can see from these numbers, there was a roughly even split of those who were in training compared to those who were already qualified, and also between those who worked as education mental health practitioners and those who were child wellbeing practitioners. The SWP refers to senior wellbeing practitioners. So these are people who we have already got their core training as an EMHP or CWP, but they either have been working there long enough that they've been given the title of a senior role, or for the trainee SWPs, we actually now have a training program where we train up SWPs. And so those who haven't specifically learned about adaptive practice as part of that course were still able to take part in this. That's why we've got a few of those on there as well. So As you can see, there was a lot of people who had less than 1 year experience, so they were all of our trainees. But then looking at those that were qualified, there was a spread, as you'd expect, the less people as the number of years of experience went on. So interestingly, we found that for the percentage of autistic children on people's caseloads, it was actually reasonably spread out across the kind of spectrum of percentages we'd asked about. So there was about 15% of people that weren't working with anyone or didn't think they were working with anyone who's autistic. And I say didn't think because sometimes we don't necessarily know or recognise the additional needs somebody might have. And then we had about 27% of people that had up to 10% on their caseload, but we also had over 12% of people who had over 50% of their caseload with autistic children. This was in quite stark contrast to when we look at the learning disability side of this. So 38% of people that took part in this said that they, as far as they knew, they weren't working with anyone on their caseload that had a learning disability, and 42% said that they were only had up to 10% of children with learning disability on their caseload, and only 0.8% of people said that they actually had over 50% of their caseload for children and young people with learning disabilities. And part of that is probably around where sometimes children with learning disabilities are in different services, depending exactly where people are working. But I think also part of this speaks to these accessibility issues. That is exactly why we're doing this research. Supervision tended to be fortnightly. Some people it was monthly, and occasionally it was weekly. But overall, it was tended to be fortnightly. But in general, fairly frequently, which was good. So the really key findings that we were interested in, what things were impacting on confidence. So we found that qualified practitioners were significantly more confident working with autistic children than unqualified practitioners, which is great. That means that people coming out of training feeling more confident when they're kind of getting out into the workforce and really starting to do this work. And practitioners who completed some kind of training or continued professional development on autism felt more confident. So that training's obviously doing something good. The more people, the more children and young people on practitioners' caseloads that were autistic, the more confident people felt working with those kids, and the more experience somebody had in their role, the more confident they felt. So all things that feel really, really positive in showing us the kind of things that we could be thinking about to help support growing confidence in this workforce. There weren't any significant differences in confidence levels between EMHCPs and CWPs. So actually, in both areas, they felt equally confident in both roles. Supervision didn't make a difference. So people that were having more frequent or less frequent supervision weren't feeling any different as in their confidence levels. And the overall caseload size didn't make a difference. So if somebody had a huge caseload overall, they weren't feeling more or less confident than somebody who had a much smaller caseload. Again, this was in a really stark contrast to the findings we had when we looked at practitioners working with children with learning disabilities. So for that work, there weren't any significant findings at all. So if somebody had gone and done some additional training, or they had a higher number of kids on their caseload that had learning disability, or had more experience, if they were qualified rather than unqualified, it didn't actually make any difference to how confident they were feeling. And I've got some thoughts in a minute about what that might mean. So overall, summary from the summary of that piece of research was that our findings suggest that some additional training and experience working with autistic children and young people improves confidence in low intensity practitioners. So that tells us a lot about the kind of stuff we can be doing to keep supporting the workforce. However, this might not be the case for children and young people with learning disabilities. Now, this could be due to the low number of practitioners doing this work. So when we think about statistics and when we're looking at numbers, if there are big differences in the number of people that aren't doing something compared in the comparison groups, it can mean that it's much harder to find a difference. However, we were finding this even when there were two group sizes that were quite comparable, like people that were trained and people that weren't trained. So my thoughts were there could be some other issues, broader issues that involved in this, and some of this is anecdotally. So I program lead on one of the programs at the university, and so talking to trainees and practitioners through that, it sounds like work with learning disabilities in particular, there's often not the level of support around that in the way that might be for other things like autism, or even things like ADHD or other areas of neurodivergence. So it could be that actually there's other things that might be impacting on this, not just low numbers. So for the future, we would be thinking about some qualitative research with these practitioners that could help us better understand why practitioners aren't feeling confident working with kids with LD, and what could potentially make a difference. So I'm going to now pass over to Cara to talk about the second part of this kind of series of research that we've been doing.
Fab, thank you, Kelly. So hi everyone, I'm Cara and I'm going to be presenting the Adaptations project. Kelly, you might need to move on the slides for me. Fab, thank you. So the aim of this project was to investigate the adaptations being made by low intensity practitioners for children and young people with autism and LD. And we were also aiming to compare any adaptations made to what the expert recommendations in the literature were. So for this study, we utilised a qualitative exploratory research design. So we aimed to collect a rich descriptive amount of data about what adaptations are currently being made. Thanks, Kelly. So we aim to hold two sets of semi-structured interviews about adaptations with ASD or LD. So our inclusion criteria was EMHPs and CWPs who were currently working in the North East and Yorkshire region. And this included both trainees and qualified practitioners. So participants were recruited through convenience sampling through, again, our university networks. So prior to being interviewed, participants also answered a questionnaire regarding their current level of experience and any CPD completed. Our interviews generally aim to cover topics such as any adaptations pre-appointment, during appointment, and then leading up to and after discharge. We also asked a couple of questions about any adaptations to the environment and communication and building the therapeutic alliance. So our interviews were analysed via a thematic analysis. So the really exciting thing about this project is it's still in progress. So far we've completed 7 interviews for ASD and our LD interviews are still in progress. So what I'm going to present today is a preliminary analysis of our ASD focused interviews. So we're still in the progress of ironing out our full thematic map, but we've got some really key themes that have emerged, which would be great to present today. So as you can see on the screen, we have our thematic map with a number of key themes and sub-themes. So I'll talk you through these. So our first theme identified in the green there was adaptations to communication. So we had sub-themes of verbal and non-verbal communication. So verbal adaptations included practitioners often speaking at a slower pace, avoiding metaphors and asking less open questions. And then non-verbal adaptations included things like avoiding eye contact and adjusting body language to help young people feel safe. A further sub-theme we identified was increased communications with systems. So, for example, practitioners would often be communicating with parents prior to appointments and leading up to discharge, as well as communicating with schools and any kind of special educational needs teachers that young people have. So our second theme was adaptations to the manualised intervention, and here we had the sub-themes of incorporating special interests and adapting materials. So adapting materials often included bringing in small amounts of the low intensity CBT booklet and removing some of the more metaphorical tasks such as the stress bucket. incorporating special interests, as you can expect, you know, leading from the child, what they're interested in. So sometimes that included adapting materials, and it also included building up that therapeutic alliance based on what the young person was interested in. So thirdly, we also identified that practitioners were making adaptations for the sensory needs of young people, and this included within appointment adaptations, such as having rest breaks and allowing fidget toys. And it also included adaptations to the environment. So thinking about, was the appointment being held in a quiet area, the temperature of the room, was there a lot of information on the walls, and trying to kind of manage that for the young people. So a further theme we identified as well was a lot of difficulties in making these adaptations, and there was a number of reasons that the participants explained that this was why. And this also included with regards to the systems, so kind of requirements by services for intervention lengths and certain materials being needed to be used. And it also included difficulties in adapting environments. This was often due to clinicians being limited by space within schools or family hubs, and kind of limited in what rooms they could use. So our final theme involved low intensity practitioners obtaining and incorporating client feedback. So what this involved was practitioners were often using creative ways to obtain feedback, and they were using this to shape the way they adapted their interventions and help them to check the understanding of young people throughout the interventions. So in summary, our preliminary findings show that the current adaptations practitioners are making for autistic young people align with those outlined in literature. Of our participants as well, half of them interviewed were trainees and half of them were qualified. However, they all described similar adaptations. Therefore, this is a real positive to take away, as it shows that clinicians of varying experience and levels of CBD are all adapting their practice for young people with ASD. Thank you.
Thanks, Cara. So we're just going to summarise a little bit about the kind of next steps that we're going to be doing as a team based on these projects. So we need to complete the data analysis around in terms of finalising that thematic map. So adding in, I know, Cara, you've got lots of lovely kind of quotes to support those different themes and really pulling that all together. And then we want to complete the interviews from the LD side of this. That feels even more important to us with the findings that we got from that confidence project, that we really want to have a look at what's happening in the LD world as well. We're going to be more systematically comparing the current adaptations that we've identified that practitioners are doing with what's discussed in the literature to see how closely that they map onto each other. And we're working towards developing an adaptation checklist. There's a similar one in the kind of adult world for when you're working with autistic adults. So we're looking whether we can develop something along these lines for children and young people that can be used in future research. And we're also looking to conduct a training needs analysis informed by all of our results to help us better identify what we need to be providing to the practitioners in our region. Future projects, we would really like to do a qualitative study now with families, carers and children and young people of their experiences of adaptive practice. So we know what the literature's saying, we know what our practitioners are saying, we now want to know what the people that are on the other side of those interventions are saying about what they're receiving. We'd like to develop a framework for adaptations derived from all three of those sources. So then a recommended framework of the kind of things that are going to optimise therapy for these children and young people. And then we'd like to evaluate that and evaluate the impact of research grounded training in adaptive practice. So just summary of all of that, for us, understanding the current landscape for adaptive practice in low intensity settings is the first step towards building inclusive community-based care, and our ongoing research agenda in this area aligns with the broader shift towards early intervention and more personalised approaches in psychological care. So it's something we're really excited and passionate about. And I just want to have some acknowledgements here for it's myself and Cara presenting today, but we haven't been doing this alone. We've got a team with us. We've got Tyler, Joe, Joanne, Jolene, Helen, Jess, Marco and Dave have all been involved in these projects. So just wanted to have a nod to those as well. And we've got a few minutes for any questions before we move on to the next presentation from Nat.
Kelly, there's a couple in the chat. Would you like me to read them out?
Oh, that'd be fab. Thank you. So I've just turned off the slide, so I can't.
Yeah, sure, that's fine.
Thank you.
So there's one from Rachel, and she said, is there an opportunity for parent carers to contribute to research on their experience of adapted interventions?
Yeah, so yes, I suppose that's what I was kind of referencing at the end, is that for us is the next stage now is now we're understanding what's happening. We now want to be reaching out to those communities to start some research around actually what their experiences have been of that practice. We also have some other projects happening as well, where we are having where a parent carer and children and young people's voices are being embedded much earlier in the research process, in the development of kind of the protocols and development of the research proposals. So it's something that we are looking to incorporate, not just in terms of finding out what people are thinking as the aim of the research, but actually being part of the research throughout.
Thank you. And there was one from Tracy as well, and I think it might have been when Cara was speaking, probably about experts by experience, and she said, oops, it's gone. Were these experts by experience actually autistic professionals?
So during when we were doing the interviews?
I think it came up when you were speaking about the interviews.
So, yeah. I think this might be, is that referencing in terms of literature, the what's in the literature around when we're doing the comparison for literature, I think, Cara?
Okay, I was thinking because we did have some of the people that we interviewed talked about their lived experiences with autism, but yeah, in terms of looking at the literature, it would be good to look at some studies as well and kind of look at studies written by autistic individuals, definitely.
Yeah, so I think that's part of that. Still said it's on the kind of in progress part of what we're doing. So currently what we've found has aligned overall with what some of the kind of key papers in the area are, but to my knowledge the people that have written those key papers aren't autistic professionals. So when we're doing that deeper dive into the research to do a more systematic comparison, that's something we're absolutely going to be including as part of that process.
And I think that was it from the chat. There is, yeah, there's not questions, just Tracy just said, I can't stress enough how imperative it is to use research and literature by autistic people.
Thank you, and thank you very much, Nat. And oh, I think we've actually got a hand up from Hannah.
Hi, yeah, I'm sorry, my camera's off. I was just curious about whether when you're gathering views from families and parents and carers, is that going to focus more on their experiences of being involved with like their child accessing a direct intervention, if that makes sense, or will it also include parents' experiences of parent-led interventions being adapted for a child's needs if the parent-led intervention is with a child who's presenting with autistic traits or has a diagnosis of autism? Does that make sense?
Yeah, and I think what we need to iron out is whether those two things are we'd be able to capture that within. I think both of those angles would be really important for us to look at, and it's whether we would be able to capture that all within one interview, or whether we might need to be actually thinking about splitting that up into two different projects. Do we want to focus on them as separate questions, or can we combine them? But I think both of those angles is something that we're interested in. So we want as much information as possible really to supplement what we've got here, because actually even if people are feeling really confident and they're saying, yeah, we're doing this stuff and it's great, if people are saying we're on the receiving end and it's not great for us, then that's that's actually probably the most important part. So yeah, I think we're going to be trying to do as much as we can in that area to gather that information. Okay, if there'll be time at the end for any kind of more overall questions, but shall we move on to our next presentation? So that's you, Nat, and I will hand over to you.
Okay then, so it's nice to see everybody. I'm Nathalie, and I'm both a PhD candidate and a lecturer at Northumbria University, working across the early intervention children's psychological trainings programmes. I've been working in partnership with young people to co-design a training resource for early intervention mental health support teams that will help them to deliver a Helix project. And that's a school community-based wellbeing intervention designed to strengthen school culture and embed a whole school preventative approach to mental health. And I'm here to talk about the project today because it really aligns with the strategic shifts in the NHS's long-term plan, so moving support into communities and adopting that preventative approach. Each Helix project will be a participatory action research initiative that places young people at the centre of cultural change. Each Helix project will be different because they will be designed by school communities, but they will all explore how authentic, non-tokenistic student voice can become a driver for transforming school culture and improving wellbeing. A key part of my research has been to understand the factors that enable or limit participation, particularly for young people whose voices are often marginalised. And through the project, the young people and I hope that we will be able to empower school communities to build sustainable approaches to improve mental health and wellbeing. So Article 19 of the Universal Declaration of Human Rights guarantees the right to freedom of expression. And part of that right is not only to speak, but to have your voice listened to, and crucially, to have it acted upon. In healthcare, we recognise this principle through the Nothing About Me Without Me principle, and it reminds us that participation and collaboration are central to delivering person-centred care. They ensure that decisions are made with people and not for them. But despite this, the majority of children and young people in this country tell us that they feel unheard by decision makers. And we also know that feeling unheard can have a significant impact on mental health and well-being. It can leave young people feeling powerless, disconnected and unseen. So as we move as a sector from a culture of treatment to one of prevention, it remains important for us to listen to and act upon the voices of children and young people, because they're the ones best placed to understand the factors that shape their mental health and well-being. If we're serious about prevention, we need to also be serious about participation. So this is where the Helix Project comes in. So it's about creating a whole community preventative strategy for mental health, one that recognises that wellbeing is not the responsibility of a single service, but of an entire ecosystem. And it's about involving every stakeholder, so schools, families, communities and services, in prioritising wellbeing. It's about recognising the potential of youth voice as an agent of change. The school community is one of the most significant in a child's life. It shapes learning, relationships and a sense of belonging. And yet children tell us that participation in schools often feels tokenistic or ineffective, that their voices are heard but not really listened to. So to kick off, I wanted to share a story which you might have heard, but it's a good one, from Professor Laura Lundy, and she's the creator of the Lundy model of participation, and she uses the analogy that she calls the problem of the yellow bus. So in Ireland, children with special education needs are taken to school each morning on a big yellow bus. From the adult perspective, this is a practical, helpful solution because we can see which children might need additional support. But when the children were asked how they felt about it, they said they hated it. They felt embarrassed, or the children made fun of them. So what the adults saw as supportive, the children experienced as stigmatising. But we only know this because somebody actually asked them. From where we stand as professionals, the yellow bus might look like a good idea, but we're not the ones on it. And even if we've worked with hundreds of children that have sat on that bus, or even if we've sat on that bus ourselves at some point, we don't really know how it feels for this child right now until they tell us. So the Children and Young People's Improving Access to Psychological Therapies Transformation Programme, it was introduced back in 2011, and it was introduced to tackle some of the long-standing challenges in children's mental health. So it aimed to address issues like lengthy waiting times and that refer-on culture that families found so frustrating. And we first saw the first mental health support teams in late 2019, and they were designed to provide early intervention through a three-pronged approach of signposting and referral, low intensity CBT, and whole school culture change, all as part of a model of early intervention and prevention. And according to an NHS England rapid impact audit, their effect was almost immediate. They improved staff confidence, increased support, reduced stigma, and even had a positive impact on behaviour and attendance. Importantly, this wasn't just seen in the children receiving one-to-one interventions. The benefits extended across entire school communities. The CBT early intervention work that the teams deliver is both cost-effective and evidence-based. However, prevention is much harder to measure. An effective whole school approach can take around 3 to 5 years to embed, and there are very few whole school interventions that are robustly evidence-based. Those that are tend to be prohibitively expensive, which creates real geographic inequity in support. And some of those early benefits have been offset by the changing mental health landscape. Even before the pandemic, we were already seeing a rise in prevalence, growing demand for services and longer waiting times. But then we had COVID, and that dramatically accelerated those trends. Mind recently reported that last year, 1 in 5 young people had a mental health problem, compared to 1 in 9 in 2017. And in 2024, around 1 million young people and children were actively referred to mental health services. Financially, children make up around 18% of the population, yet children's mental health services receive around 1% of the NHS budget. So while service improvements like mental health support teams have been effective, demand continues to far outstrip supply, and we need to find ways to increase our impact. We can already see this pressure reflected in our schools. So in 2022-23 academic year, exclusions rose by 44%, and the numbers increased again last year. There were nearly 11,000 exclusions, and 39% of those were due to disruptive behaviour. In the same year, there were about 950,000 suspensions. Again, half of them were for disruptive behaviour. So what's going on? There's several recognised risk factors for exclusion and suspension, including pressure around academic performance, having SEND, being male, being economically disadvantaged, and belonging to certain ethnic groups. The socio-political view is that these figures reflect increasingly complex needs and challenging behaviour in our schools, and the schools simply don't have the resources to meet these needs. This, of course, has mental health implications, and we've got students with complex and often unmet needs in education settings, and these settings, despite their best efforts, are struggling to cope, and this is showing up in classroom behaviour. Schools, often under pressure, respond with stricter behavioural policies, maybe around uniform, toilet access or equipment, in an attempt to maintain order. So we've got this perfect storm of overstretched mental health services, overstretched education systems, and students whose needs are not being adequately met. And to meet need, we need to change our strategy. It's a really overused analogy, but we do need to focus on stopping our young people from falling into the river rather than throwing them a life raft. So that's the data, but how does this feel for the young people themselves? So I've been working with young people undertaking a King's Trust educational programme. They're all students who faced multiple significant challenges affecting their education. And when I first spoke to them about the Helix Project, one of the first things they said was, "What do you want to ask us for?" So across different interviews and group discussions, the themes that arose were consistent. The students described tokenistic approaches to student voice, where only a few select students were asked to contribute, and it was often about matters that the students saw as irrelevant. So as one student put it, they'll ask us about what colour to paint a bench, but not about the things that actually matter. Many students also spoke about a punitive culture where instead of support, they were met with sanctions or consequences. Students who struggled with anxiety, bereavement, or unmet neurodivergent needs were punished for behaviours that were signs of distress. There was also a clear message about inadequate mental health and SEND support, so long waits and education staff that didn't have the time or the training to help them. They talked about needing trust and needing safe and confidential people and places to open up to. They highlighted a sense that schools prioritised reputation and results over well-being. So attendance targets, Ofsted ratings and behaviour policies came before understanding what was really going on. Lots of the students gave me the impression that they'd slipped through the cracks. So one said, "I had to get excluded and have a fight just so they'd listen." And interestingly, many students reported that college felt completely different. Smaller classes, respectful relationships, and a focus on well-being rather than compliance. Their recommendations were really clear. And considering that in the beginning, the students felt that their opinions wouldn't be worth anything, they were consistent with the research, with Professor Laura Lundy, with the NIHR review of MHSTs. And they said, listen to all students, not just a few. Act on what's heard, safe spaces and trained staff, and focus on understanding, not punishment. I think that their overarching message was that young people don't want us to presume what they need, they want to be heard. And I think we have a really strong argument there from the young people themselves for participation and co-production when we're thinking about culture change within our communities. Have a little sip. So effective whole school approaches play a vital role in shaping positive and inclusive school communities, and they benefit both staff and students. Yet implementing these approaches can be challenging. It's rarely appropriate or effective to enter a community and say, "You're doing it wrong, let me fix it." And this is particularly true for the mental health support teams whose work depends on building strong relationships with schools. Suggesting numerous changes without understanding the community can be counterproductive, and even the most experienced professionals cannot fully know the context of a particular school community. The most effective approach is to develop change with the community, not to it. So Rosa Beth Moss-Cantor is a sociologist, and she explains, when change is done to people, they experience it as violence. When they do change themselves, they experience it as liberation. Working collaboratively serves two purposes. It builds trust and relationships, and it provides insider knowledge that supports sustainable, effective culture change. Embedding a preventative culture is not a one-off intervention. It's a long-term process of genuine system and cultural transformation. And this process is continuous. Collaboration leads to action, which generates new insights, which then inform further collaboration and improvement. So where do we start? According to the research, one place is with the strengths already present within the community. So Harvard's 75-year study on community development highlights the importance of building from existing assets, skills, networks, resources, and lived experiences to create sustainable inside-out change. Top-down approaches carry significant risk. When communities are defined by their deficits rather than their strengths, funding often prioritises external service providers over the community itself. And people within that community and students within that community may begin to believe that change can only come from the outside. This undermines active citizenship and long-term community ownership. So I think it's really important that we act as collaborators, working alongside school communities and recognising and building on existing strengths and fostering meaningful, sustainable change from within the communities. I created the SPANS model to illustrate that process, and it's based on the process of participatory action research, which is a collaborative approach that involves communities coming together and collaborating to create positive change. Participatory action research is rooted in the principles of equity and social justice, and it gives individuals and communities ownership over the issues that affect them. Okay, I would say that's probably it from me, but I wanted to emphasise one key principle. Youth voice, student voice is essential. When we genuinely listen to young people, they feel valued, engaged and motivated. Their voices strengthen relationships, boost well-being, and they foster ownership of their learning and school community. But student voice can be tokenistic. Tick box consultations teach young people that their opinions don't matter. So in order to be authentic, student voice requires creating real opportunities for co-production and meaningful participation. So we as professionals have the chance to model authentic listening, not just in crises, but in everyday support and preventative work in the creation of policies, processes and practice. And when we get this right, the whole school community flourishes. And that's the core of the whole school approach. It's the core of community development, and it's the core of developing a culture of prevention. And thank you very much for your time and your attention. I have put my email on there in case you wanted to get in touch. I would be particularly keen on hearing from mental health services that would like to support and deliver pilot Helix projects. But I'll pass back over to Kelly. Should we check and see if there's any questions in the chat first, though?
Yep, so we haven't got any questions in the chat at the moment. So shall we open it up to everyone if anyone's got any questions for Nat? Hannah?
Hi, Hannah.
Hi, it's me again. I really enjoyed your talk, Nathalie, and hearing more about your project. I work in a mental health support team, so obviously a really key part, as you mentioned, is that sort of whole school approach, and you've reflected there on some of the challenges that there can be with sort of embedding that and evaluating the effectiveness of that kind of work as well. Sorry if this isn't articulate, I've sort of got a lot of thoughts in my mind from you talking. But something that I was reflecting on whilst you were talking, you sort of mentioned about the feedback that you've had from participants in the research, from young people who've spoken about that perception of schools prioritising reputation and attendance targets, Ofsted ratings, behaviour management policies and etc. over genuine participation and promoting well-being. And I have a lot of compassion for education settings in terms of the different directions that they might feel pulled in terms of all the things that they are being asked to prioritise.
So yeah, I completely agree with you.
Yeah, And I don't know whether I really have a question, maybe it's just more of a reflection, but obviously a lot of those expectations on schools come from higher up. You know, you were talking about the limitations of that sort of top down approach, and I'm sort of thinking about how that applies to, you know, the Department for Education and other sort of government initiatives also trickling down into what's expected from schools and colleges, and you know, just sharing that reflection that if, you know, schools feel pulled in a certain direction, that they're having to evidence all of these things and they only have so much time in the day, you know, they're with my experience of collaborating with schools, there is often a desire to do more, but the message that we get time and time again is just struggling to fit that in and prioritise that in existing workloads. So I guess I just wanted to share that thinking and see what your thoughts were.
And I understand it. A really good way, I think, of getting in is I'm the Send and Wellbeing Governor of a school, and I absolutely love it when parents get in touch with me or when I can get involved in things, and I really push for we've got a student voice project in our school at the moment, which is amazing. So it's a really good kind of, I think governors are keen to engage with all of the school community, and it's a good way of getting in there, I think.
Got a question from
Sharon? Yeah, it is something that we consider as part, sorry, just to respond to that, it is something that we consider as part of our sort of review of mental health provision. Is there a sort of mental health and wellbeing governor in place? But we have quite limited contact with them. But is it? I'll take that comment away in terms of that might be another route in terms of championing that kind of working.
Yeah, I'd recommend it definitely. Hi, Sharon.
Hi, Nathalie. I really love it when you speak about your work, and I kind of think as Hannah was talking, I was thinking about Bron von Brenner.
Yes, Bron von Brenner, it's so important.
And the systems within which the multiple systems within which we work, and that kind of interaction between those, and the impact that has on development, not just for children, but for us all across the life course. And I think as psychological practitioners, I think it's really important to hold on to where we can operate and influence. So as you're talking, I'm thinking about the individual, you know, those kids, those young people in school, and thinking about that ecosystem, about the policies and procedures that influence what goes on in the school, and how sometimes I move much towards sometimes how we as psychological practitioners, some of us need to be a bit political, because some of the contexts within which we work are quite ideological, and how do we navigate that territory as psychological practitioners to influence and inform?
So there's some research that says interventions within the meso system, if we're thinking about Bron von Brenner, can be the most effective. So that would be MHST speaking to school staff, and the child doesn't actually have to be involved. So it doesn't always mean speaking directly to a child. It can be speaking between professionals to enable student voice. And I think we do have to actually work that way, because we need to get the permissions and the bureaucracy in place.
Yeah. So there's multiple levels I think we can operate at that might help. I think sometimes it feels, Hannah's sense of feeling quite overwhelming. Where do you find the space to do this? Where's the capacity? And I think if we can think about that, we all some of us are operating at different levels. How do we maximize that for ourselves?
Yeah, there's a massive need for us to increase our impact in difficult circumstances. And I know within MHSTs, there's like a 24% vacancy rate. So it could be one EMHP from every mental health support team. So we really need to find ways that increase our impact without increasing the stress and the pressure on our teams.
We've had one thing in the chat. So Hannah said lots of interesting information. Is it possible to have a summary of the project sent around, or is there a way to access the information online?
Yes. I can sort that out, no problem.
I think, Kelly, there was a general question about accessing the overheads. They call those the slides. Are you happy for us to put them online?
Oh, I muted myself. Yes, absolutely.
Thank you.
Okay, so if that's all the questions for Nathalie, we'll pass over to Clare Devanney-Glynn, who's going to be talking about parent-carer peer support. And I've just realised I'm also doing Clare's slides, so just take a moment to share those.
I think I'll introduce myself as well a little bit more. So my name's Clare Devanney-Glynn. So I'm a consultant lecturer at Northumbria, and I'm the lived experience lead for the Children and Young People's Psychological Trainings Programme. And my lived experience comes from the, well, to say it's been a journey just doesn't even come close to what it's been, but I am the adoptive mum of 3 teenagers with FASD, so fetal alcohol spectrum disorder. And I adopted my babies when they were babies, and they are 18, 19 and 20 now. So I have been in the trenches for 2 decades, and that is how I am now an expert in this area. And I feel really passionate about what I'm going to be talking about, because in all honesty, the greatest difficulties have been caused for my children, and as much harm has been caused to my children from trying to access education and services that only exist to support them as their early experience in life. So this is something I'm so passionate about. And before I get into the slides, I think I was thinking about this morning, and you probably have all heard this. It's like a little quote, and there's lots of different tweaks to it, but I feel that it quite often sums up the role and the power of the parent-carer peer support worker. So a parent of a child with mental health difficulties fell into a deep, dark hole, and a family member said, "What hole? We can't see a hole." Your boss might say, "Oh, that's a shame. You can take a day off, take a day's leave if you need to sort that crisis out." A doctor might ask you to keep a diary of your experiences when you're in that hole. CAMHS will be able to assess the hole in 18 months' time. And I'm not bashing CAMHS. I see myself as part of this workforce, but this is the reality. And I know people who work within those services feel this frustration as well. The local authority, I'm sorry, we don't have the funding to be able to buy a ladder to get you out of that hole. Charity, yeah, we can help. Here's a form to fill in for you to apply for the funding to be able to get the ladder. And then a fellow parent of a child with mental health difficulties. It makes quite emotional. I'm coming down. I've been in that hole. I know what it feels like. I know how I got out, and I'll help you get out. I won't leave you in there on your own. And I think that just sums up the power of this role. So I can have my first slide, please, Kelly. So the role of the parent-carer peer support worker in children's mental health services is that they use their own lived experience of supporting a child with emotional or mental health difficulties to help other parents and carers who are navigating similar challenges. And they provide parents and carers with emotional support and information and empowerment. And I think one of the huge plus points to this role is sometimes your roles can be difficult because it might be a tricky dynamic with parents and carers, because let's make no bones about it. If you are a parent or a carer and you have had to access professional strangers to help you parent your child, you are at absolute rock bottom. There is no worse or scarier feeling than that. And I think the parent-carer peer support role helps parents and carers to manage that relationship properly with professionals, because they offer empathetic, non-judgmental listening based on shared lived experience. Because the power of somebody being able to say, "Oh, when that happened to me, this is what I did," or "When that happened to me, this is how I felt." You can't can't kind of teach that. That has to be earned. And you know, we know I'm always very conscious of not saying that these roles, well, this is the melting of these two roles. This is a professional and a parent-led role, that, you know, melting the professional learning and the academic learning together with the lived experience. And it helps parents feel less isolated. And most importantly to me, it helps them feel less blamed, because there's such a huge element of blame. And I think I'm very privileged, full stop. I've had a very difficult journey trying to keep my three alive in the most basic terms. But I've always had a kind of a get out of jail card. I always feel like I don't enjoy being seen in this way, but I'm often seen as like a bit of a saviour, like adopted 3 children out of care. And so I get a lot less blame. I still have had awful experiences where it, you know, everything that's going on, you know, never mind the alcohol, the brain injury, the developmental trauma, the sensory process, and never mind all of that. It must be what I'm doing wrong as a parent. That has been lots of that. But it's always been accepted that I've kind of picked up a situation and ran with it. But I support lots of families where the sense of blame and shame that they feel, that they think, well, this has got to be my fault. This can't be anyone. This has got to be my fault. So I think this role kind of helps parents and carers separate that out, and it helps them to understand why things are happening, what the role of services are, and how you can work together. And it provides lots of hope and reassurance, showing that recovery is possible, because lots of parent carer peer support workers that I work with, some of them are still in the thick of their journey, but a lot of them are through the other end and have adult children who, and you know, they've kind of gone through their journey and come out the other end, and that provides masses of hope for people. Next slide, please, Kelly. So the role of the parent carer peer support worker is to help parents and carers navigate services, strengthen family resilience, work collaboratively with professionals to improve outcomes for children and young people. And this unique role, it does bridge gaps between families and professionals. And I've seen that happen, because quite often you'll read the description of something and you'll think, well, that one little sentence, that's a lot to ask. But this role in practice, in action, it's incredible what it can achieve. And it ensures that parents feel heard and supported and empowered throughout the journey. And I think that it can, you know, it can help, most importantly, help parents and carers understand how mental health services work. So, for example, referral processes, assessments, treatment options, and it can explain what to expect from services such as CAMHS, crisis team, and school-based support, so it can work very closely with MHSTs. Share information about community resources, parent workshops, help self-starter strategies, and encourage parents to develop confidence in communicating with professionals, because in my experience, that's where I've seen so many situations fall apart, which can also make it way worse for the young person, because it is, you know, as overwhelming as it is for the parents and carers to be navigating this. Obviously, it's the young person at the root of it all, and it is the most overwhelming for them trying to survive a situation like this. Advocacy and empowerment, I think that's a huge part of the role, because when you're sat next to somebody who has been in that situation before, so for example, knows what it's like to be in an EHCP review meeting, because a lot of those things are really daunting. And if you've never worked in an area where you've had to speak to people, or you've had to have your voice heard, sometimes people can just shut down. And then sadly, so if there's not a voice shouting loud enough for the child or the young person, then things maybe won't get done to the capacity that they would have got done had that voice been there. So the role is to empower the parent and carer to do that, so they can kind of navigate what's meant to happen, but always with the goal of encouraging the parent and carer to be taken on that role themselves. Help them express concerns and ask questions in a constructive way, because quite often when parents and carers are overwhelmed and in the depths of this battle, because it is a battle, and you know, I know that I'm not speaking out of turn there, I know that you as practitioners, you see this, we're all human, you see how hard it is for these parents and carers to navigate, and sometimes they might not do that in the best way or the most effective way. So it's encouraging them and teaching them how to do that confidently, and promoting co-production, which is in the root of it all. And you know, as a little aside, I think that the role that I'm in now at Northumbria University, 10 years ago, when I was trying to get my children's voice heard anyway with local authorities, with primary care, with education, it wasn't even a pipe dream that a role like mine would even exist, let alone be taken seriously and have an equal voice, like a genuinely equal voice. It's not, I feel gone are the days where lived experience co-production are tick boxes, and this role, this professional role within the workforce is evidence of that. So it helps people work collaboratively with clinicians to improve understanding of family perspectives and barriers. Facilitating peer group support or workshops where parents can share experiences and coping strategies. And what I've witnessed over the years is there is nothing more empowering and confidence building than parents and carers being in an environment where they feel safe enough and not judged to be able to share their voice and share their experiences, and other people gain from that. And that, I personally have found that so cathartic throughout my journey, and that's why I've pushed myself to do what I do, because that's helped me recover from the trauma that I've suffered throughout our journey. Yeah, so next slide, please, Kelly. So the value of the role, I mean, it's invaluable to me. And I think, and when I say this, I'll often say, when it comes to the parent carer peer support role, somebody who has been in the arena that you find yourself in, kind of fighting that battle and trying to climb that mountain, they hold so much more power in your mind. They instantly have your trust, and they have the capacity to cut through what it might take 4 or 5 professionals to get through, simply because of their experience and that shared experience. So they have so much to offer the workforce, giving a safe, non-judgmental space for other parents and carers to learn from each other. And for services, this is an invaluable way to boost capacity in the system. So we're building on partnership work with voluntary sector organisations, and it is unique, and it does bridge the gap between families and professionals, because it's a long journey, the mental health journey with your child, and it's terrifying. It can provide feedback to teams on how services are experienced by parents, which helps improve accessibility, engagement, contribute to team meetings, care planning and service development from a parent's perspective. And the professional practice element of it all. So it maintains clear boundaries, because it offers peer-based and not clinical support, and works within safeguarding and confidentiality frameworks. And parent carer peer support workers receive regular supervision and training to ensure safe, effective and reflective practice. Next slide, please, Kelly. So how can this role benefit the workforce? Improved engagement outcomes, support clinicians and reduce the pressure on clinicians, enhance communication and understanding, promote a compassionate and inclusive culture, workforce development and retention, and enhanced outcomes for children and young people, all while modelling the power of lived experience. And they are huge statements to make. And I think that using the lived experience to provide emotional support, it empowers parents and carers, helping them to navigate these services. And So one of the huge benefits that I've seen with them, so when it comes to supporting clinicians and reducing pressure, so just one little example, imagine the neuro pathway waitlist, which is just an absolute minefield. And you'll know from your experience, once you as a family have a child on that waitlist, quite often you'll get, if you're trying to access any immediate support and help, you'll get bounced back because, oh, you're on the neuropath, you're on that wait list, and that can be terrifying and so frustrating. And I think, and as clinicians and as professionals, I used to sit on the outside of all of this as purely as a parent carer, but now in my professional capacity, I know for a fact that it is as frustrating for all of you, because you are in this role to help people. You want to make a difference to society, and so it is just as frustrating for all of you. So one of the huge examples that I've seen in practice, and the power of it, is supporting people working with families who are on that wait list, who are sitting in there just to share their experiences of when they were particularly sitting in a wait list, waiting to be assessed, or waiting for a decision to see if they were going to be assessed for some kind of a diagnosis or a forward plan, and able to put very, very practical strategies in place, around things like meal times. When I couldn't get them into school, this is what I did. This is how I communicated with school. This is how I got them to see our side of the situation. So, and that in turn reduces the pressure, because from a very practical point of view, reducing repeated contact of ever increasing the frantic parents getting in touch when things are escalating and mental health is kind of falling apart. So I think that I've seen that firsthand. I've experienced that on both sides of the role, because I do lots of peer support within the fetal alcohol spectrum disorder world and the adoption world. So I just think that, this role is, sometimes it's difficult to explain the power of it. And I probably am a little bit biased as well, because along with Nat, I'm a co-program lead on a training course that delivers the training for this program. But I'm only doing that because I have lived the power of the role. I think I've got one more slide, Kelly. Oh yeah. So I've whizzed through that. I don't know if there's any questions in the chat. I don't know if anyone's got any questions. Is there anything? No, I don't think there's anything there.
Has anyone got any? Thank you, Claire. Has anyone got any questions for Claire?
Tracy, I wonder how many MHA colleagues stand with 1 foot each pool of experience, trained mental health professionals, caregiver. Yeah, I feel in my experience, the people that I've encountered have got into these kind of roles because of where they've been. I mean, the MHSTs, like they are some of my absolute favourite people. They're the people who I love to get my hands on, because of the power. If my kids, because honestly, and I can back this statement up, our education system caused more harm to my children than the experiences with their birth parents. 100%. Caused more harm to their mental health than that. And at 18, 19 and 20, I am on a daily basis, until around about 3 o'clock this morning, actually, outside in the rain, trying to calm one of them. I'm still trying to unpick all of that. And if we had MHSTs back then, it's not even life changing, these roles. They're life saving. And I am quite a dramatic person, and I do like a little bit of drama. But that is a simple fact. I'm not being remotely dramatic there. These roles save children's lives. It's just but so frustrating, because and so such an emotive role. It is a really emotive role. So I could talk forever about how to support parent carer peer support workers in the workplace because of you know what they juggle. Rachel, you've got a question?
Yes, thank you, Claire, for really bringing the role to life. And it feels like, where are you all? I would love more of you. Where are these roles usually employed? Could you let me know?
So I think in our experience, because it's still a relatively new role, I think we've got a lot of third sector. So there's a lot of these roles within charities. I think Nat, Nat, are you still there? Nat might have a little bit more. Nat might be able to answer that question a little bit better. Nat, do you know?
Yes, so we do have a lot of third sector charities that people work for, but we are seeing it increasingly in NHS as well. And we and the training, we help people to navigate, because it's a role that has a foot in both camps, I think, and we help people to navigate that. We've also been working out how we can have the PCPS role as part of mental health support teams, because I think they could really add to the teams in that. It's probably a financial conversation that's not suitable for this, but if you'd like to get in touch with us, then we can help out with that, and we can do a one-to-one meeting with you.
Oh, thank you. Thank you very much.
Sorry if you're dragging you back in there, Nat. Hannah, I've just been reading your comment there. So yeah, there are some employed by NHS trusts, and that's mine. You know, so I just feel like, and I feel like it will start and snowball, because it's like a little bit of it felt like a little bit of a stalemate for a while, thinking like, well, where do they sit? Who should, you know, what benefit will there be when we employ them? And it's a kind of, they need to be in place for you to be able to see the benefit that they do have for them. You know, it's a no-brainer for me. And when I say they can, like, I genuinely feel that in these situations, they can have the power of multiple professionals, and that is not taking anything away from a professional role at all. It's just the unique nature of this role. And I think that, you know, our job now is to try and get as much awareness of the role, get as many services buying into the role. It all comes down to money, doesn't it? Buying into the role, and then parents and carers will be able to find out, you know, they'll be advertised as roles within those teams. So it's like we're trying to, the momentum is definitely building, and it's been like, we feel like we've been pushing a train uphill for a little while, but there's two courses running immediately into the new year next year, so we're starting to fly now, because it's people are starting to see the power of it, and there's something I feel really strongly about. There are parents and carers who are doing this all over in a non-professional capacity for free everywhere. I have done it for 2 decades. You know, going to meet with a family in a school next week and help and train there's no funding there for it, but you know, if I don't, they're going to sink. And I just think that the way I think about it, keep putting that out into the universe, and I'll get me rewards by more and more of these professional roles being in place, and I'll have to do that less and less, unfunded for free. But so oh, thanks, Nat. Nat's put the link in the comments for the training for the Charlie. So we're in conjunction with Charlie Waller Trust, the charity. But it's a fascinating role, and it's really, and I think in a very short space of time, it will just be a business as usual role. Most teams will have it because of the necessity for it. I don't know if there's any other questions. No, well, thank you. Thanks for listening.
Okay, thank you very much, Claire. So if we open it up now to just any remaining questions from the session today, is there anything anyone else would like to ask, or any reflections that people want to share? Yes, Hannah.
Sorry, I hope I'm not being too dominant. I've really enjoyed all of the talks today and got a lot of thoughts. So I had another question about the first talk, the second project, about adapting interventions for autistic young people and young people with learning disability. And I was really curious about whether there have been any themes that have come out, or to be fair, I don't know whether these themes would have come out more in project one, but whether there had been any themes that practitioners were reporting around the suitability of low intensity CBT interventions and the sort of skills and strategies that are covered within them to meet the sort of emotional well-being and mental health needs of autistic children or children with learning disabilities, and whether it is within the scope of the research that you are doing to explore whether there are any sort of key needs that aren't being met by those interventions, and considering how those needs could be better addressed. I suppose I'm thinking about things like something that comes up quite commonly just in my own practice, for example, might be autistic children and young people who might be struggling with alexithymia and struggling with sort of identifying and communicating about their emotional experiences, and then that can be a barrier to then being able to get the most out of some of the strategies that we're trained to support them to develop. So yeah, I was just curious to see whether you had any thoughts about that.
Cara, I'm thinking, I know you've been more closely involved in the thematic analysis parts. My first thought was, I think the questions, the interview schedule that we developed didn't have a huge amount of space for exploration of those areas. But I don't know, Cara, if there were any bits that you noticed when you were doing the kind of working through the transcripts that fit with what Hannah's talking about there.
Yeah, there was definitely some elements, and I think all of those bits would be included in that theme where we talked about in difficulties with kind of the services and the systems. And I think there wasn't huge amounts for it to be its own developed theme, but I think it is really interesting, something that it would be good to explore. I think a lot of what our clinicians talked about in the interviews was more about struggles with, the amount of sessions. They don't have time, if a young person struggles to communicate, they don't have as much time to kind of slow that down and allow that communication, or them to figure out, what works best. But yeah, it would be something really interesting to kind of, like we said, expand the study and look at more.
Are there any other questions? So one in the chat, same question regarding autistic masking with low intensity anxiety work around exposure, and have encountered difficulty with not encouraging teaching children, young people to mask. So saying kind of similar thoughts about the challenges potentially within low intensity anxiety work, and I suppose with the hope is with the senior wellbeing practitioner role that's going to be enabling. So part of that, the intervention is talking about allowing learning around adaptations and allowing some of those other adaptations around more time to work with some of these added aspects. But because it's so new, and because we also know that it's not just the SWPs doing this work, it is everyone doing this work. That's why we want to figure out, actually, is there other training or things we need to be thinking about within the other curriculums that needs to go in there, given that people are doing this work anyway. But I think, yes, these are really, really important things for us to be thinking about. How it's I suppose that this research came out from the idea that at the moment it does feel like the current setup of low intensity services can be a barrier sometimes to these children and young people accessing those interventions. Yes, Tracy?
Hi, can you hear me first of all?
Yes, we can, yeah.
Okay, sorry, I'm sat in my car. I've been listening to this while I've been driving along and then pulling over to type my little bits. So if they don't make sense, that's why. I really love all of these questions that have been posed, because this links into my point earlier, where it's really, really, really important to read the work of autistic professionals, academics, autistic people themselves, autistic adults who have lived that childhood that we're working with now. You know, and they have amazing information and advice and ideas on all of these things, in interoception work, alexithymia, you know, when CBT can feel a bit like gaslighting, when actually autistic young people's worries and concerns are genuine and rational and well-founded. So please, as a starting point, I would advise everybody to go and have a look at either Spectrum Gaming's website or the autismunderstood.co.uk website. They are autistic-led websites, and they have some really lovely advice on there about working with young people around anxiety and worry and things like that. And that is created by autistic people who are working with young people. So it's co-produced with young people and autistic adults as well. So really, really helpful information on there is a good starting point. So I'm going to stop there, because otherwise I could just talk for 10 million hours. Thank you.
Thank you, Tracy. And I think, you know, as an autistic clinician and researcher myself, I do think it is really important that we are making sure we have that inclusion at every level of these projects and intervention development and implementation. So yeah, I think it's a very, very important point, and something we certainly think about a lot at Northumbrian within our team in terms of how we embed this in our research. So thank you very much. I think we are just about at time. So if anyone has any more questions, please do feel free to email any of us. We're always happy to speak to you about the things that we're doing. And I will hand back to Sharon to close.
Thank you so much. Thank you, Kelly, for brilliant sharing. Thank you, Claire. Really brilliant, inspirational. I can feel your passion through the screen. Thank you. Thank you, Cara, and thank you, Nathalie. And thank you all for coming this morning to our first North East Yorkshire PPN session. Really brilliant talk. Thank you ever so much. And we will, at some point when I work out the tech, upload the recording onto the website. And if Kelly, if you're happy to share your slides, we can do that too. Have a really good day, everyone else. Thank you. Bye. Bye.
Thank you.
Thanks for your time, everyone.
Bye.